to take a look today at a little bit of the history of child therapy, just a little bit, and then where science comes in. What is science in psychotherapy with kids? A bit of a look at what's scientific versus what is a bit of pseudoscience or things that are not ready for prime time, and why it's important for us to lean on the science side and where we might go from here. All right. But first, let me look to where I was yesterday. This is the view from across the street, Prospect Park in New York City. We've been cold up there, and I want to thank the people at the Soleil on the Ocean for having my room temperature set at 34 degrees so that it felt like home. But this is where I started, actually. I started in Broward County at Kids in Distress, for any of you who know this wonderful agency in Wilton Manors. I was a child and family therapist there working with a master's degree at the same time with Broward County Child Protection Team. So I was doing a lot of evaluations of kids who were abused and also for the Child Protection Team, we were doing evaluations of children plus alleged abusers and such. And this was back in the early 80s. I got a lot of experience. I'm from Pompano Beach, or at least I moved there when I started high school. So I spent a lot of time in Florida for my education and then also for a number of years working in the area of child abuse and neglect. And one of the things that happened is I wound up being certified as an expert witness for Broward County Court and got a lot of training over time from various child abuse agencies throughout the country on how to determine whether a child had been abused. And it started to hit me as I was sitting in courtrooms being questioned and comparing my testimony to what I heard another expert witness for, let's say, an alternative view, the other side talking about what we were using data and how we were using data to support our statements as to whether we thought, and we were making recommendations to judges as to whether an individual was an abuser and whether a child was abused. Now, of course, the cases that came into question were where kids were too young to have consistent or clear recall or description of what may have happened to them, especially when there was no physical evidence. And what we were relying on was work that was out there saying that if a child sits with a set of anatomically correct dolls and takes the clothes off of these dolls, well, obviously you're looking at a child who has been exposed to sexual content. Wow, I started wondering with myself, wait a minute, is there data to support this? How do we know this? And at the time, which was in the early 80s, if you all remember the McMartin case and things, things were heating up about child abuse. Well, in digging into the literature, all I could find at the time was really anecdotal case study evidence, not clear and good, valid evidence on how dolls are used and whether kids who had been abused versus those who hadn't played differently with dolls. So this scared me very much because we're offering our opinions to judges about people and what happens to kids in terms of placement and protection and what happens to adults and such. So that sent me running back to school to get a Ph.D. to really understand what are the tools that we have both in assessment and also in treatment. How are we using those tools? And what's the veracity, of what it is that we do? So with that, I headed to Mississippi and then beyond and beyond and studied clinical child psychology. And, first of all, just in understanding where this all happened, of all things, the treatment of kids in psychotherapy isn't that old. It's only over about 100 plus years old. The first case of treating children was in Pennsylvania, Leitner Whitmer's program, where a young boy, mostly for a learning disability, was brought in, and this was the birth of clinical psychology, and this was the first child case. And then, of course, there's famous cases like Little Hans, where Sigmund Freud was studying a young boy with phobias. Moving on over time, a focus on children picked up steam. Clifford Beers began the mental hygiene movement, from which child guidance clinics were formed, and then these started appearing throughout the country, and these were focused on giving mental health treatment, the best that was available to kids. Now, and mind you, there's a lot that went on in the early part of the century in terms of the best that was available, might include things like ice water dips and spinning in chairs and things like that. But, you know, some things come on and then they go. And of course, the Judge Baker Foundation really started focusing on mental health issues in children, and Judge Baker Foundation survives in its form at Harvard Medical School and continues to work very much being in the forefront of treatment for children. The predominant traditions that emerged from this early work were psychoanalytic, where a focus was on the child and helping children through dynamic therapy to, through play and observation, understand themselves, develop insight. And so there was an interaction in terms of development and the child's unconscious through play and the interpretations that therapists would have as to what was going on with the child. And Dibs, of course, I don't know, in high school I picked up Dibs, read it through college, one of the most famous works by Virginia Axline. And of course, we had others like Melanie Klein and Anna Freud who focused specifically on children. And then this is a classic view of a child play therapy room, a sand tray room, where where therapists will set up a room in such a way where kids come in and then they work with the sand tray and the toys that are around them in this type of therapy. At the same time that analytic therapy was taking hold, cognitive behavioral therapy's very early roots started to take shape. And the person responsible for cognitive behavioral therapy, really with children, was Mary Cover Jones, who was a graduate student at Teachers College at Columbia University, needed a dissertation, and was able to collaborate with John Watson, the founder of behavior therapy. He had demonstrated you can condition fears and phobias. What Mary Cover Jones' work did in her dissertation with 3 young boys who were all around 2 to 3 years of age was demonstrate that you can decondition kids who have significant phobias. So this was the very early work in the behavioral paradigm of looking at how to resolve through behavioral means, shaping a person's behavior through systematic desensitization, or what would become systematic desensitization. But it also was the first real data-driven as opposed to just descriptive about what was going on. They were taking data points at every minute or so throughout the course of the kids working with these animals and being put in the same place as a white rabbit or a white rat to decondition their fears. This laid the foundation for later development of cognitive behavior therapy, which didn't really happen then until the 50s and 60s. So time went on with cognitive behavior therapy developing, and then also psychoanalytic, and these were the 2 mainstays of therapy, both for adults and then also for kids. And things were moving along pretty smoothly, people in their own little camps doing their thing, until the 1980s. 1980s was a game changer in many ways. Just in the field of cognitive behavior therapy, we really married the cognitive and the behavioral into CBT. But more so in the country at large, there was a sea change in what was going on in terms of reimbursement and treatment services in the US. At this point, managed care really started to corner the market on how people would be treated across the disciplines in medicine. And the focus in managed care and by third-party payers was that short-term and effective treatments needed to happen, whether it was in cancer, cardiology, pediatrics, or mental health. In mental health, this shifted then the change away from thinking long-term into, okay, focusing on giving relief in the immediate and having outcomes that could be viewed in the immediate, and approaching the child, if we're talking about child therapy, in terms of their whole context, taking a look at them very deeply and broadly to see what needs to be dealt with right up front to give them the most immediate and lasting relief that can happen, and taking into account family factors, socioeconomic status, and such. The emphasis out of managed care and out of the change in these political movements that were going on behind the scenes was on empirically supported treatments. That we had to, and insurance companies wanted us to start demonstrating that we were using empirically supported treatments so they'd get more bang for their dollars. Bear that in mind. Now, the thing about it was, this really wasn't the mode. This wasn't the way that things were working. People got into therapy, stayed in therapy, or the therapist did what they could do. But, insurance companies at this time, actually, we did not have parity. We were not getting reimbursed as psychologists. I don't think social work was getting it in the same way either. It was pretty much you had to be a physician. So insurance companies were not reimbursing for therapy. The view from the field at large, insurance companies, medicine and such, was that we're all the same who do therapy. Those of us who do psychotherapy, didn't matter what school you graduated with, didn't matter what degree you had, didn't matter where you came from, what you were doing. Therapy, psychotherapy was this thing, it's one thing, and you're all alike. And this actually wasn't true. We know that. We have differences in the way we practice and what we do, what we focus on. We specialize in such, but that wasn't the way it was. And the other thing that was happening at this time is that because the insurance companies, managed care, was demanding accountability, demanding evidence-based treatments, medicine was determining what was evidence-based and what were the practice guidelines that insurance companies should reimburse for. If a therapist followed these guidelines, then they get reimbursement. So this was problematic for us because we are trained very differently from physicians, and we do things quite differently. We don't have the same armamentarium, right? So it was important for the field of clinical psychology, clinical child and adolescent, to stand up, be heard, and to make statements as to what we do that is evidence-based and how it should be delivered. There's a lot of reasons for this, of course, not just from the perspective of being in the same ballpark so that we can get reimbursement, but also for the protection of patients. I mean, really and truly, when it comes down to it, it's for the protection of patients. Because we need to, by having evidence-based training and evidence-based treatments and assessments, we then will assist patients in getting the best that they can, and also helping to separate from what are untrained, profit-driven types of therapies that really don't move the person along in terms of a way of helping them to recover and move on in their lives. We also had heard, and there's plenty of issues regarding safety in treatments that are not well studied and understood, okay? And we're going to talk about some of that. And besides the fact that when you're in a treatment that isn't going anywhere, doesn't have a place to go, there's a lot of money that gets drained from the people who are paying for it, and then also if they're trying to use third party, in that way, it's a drain on resources in that time. Most importantly, I think from my perspective when I work with patients is they lose hope. They lose hope if they're in a treatment that's not meant to be a treatment to help them move along. It solidifies their diagnoses, causes comorbidity, and I'll talk about that in a minute, and much lost time. And when we're talking about kids who only have, if we think about it, 18 years to be kids before they're launched into, okay, be an adult, and if you have issues while you're an adult, you have time to remake yourself, renew yourself. We see this all the time nowadays. A celebrity or a politician falls in some way, and they come back, they reemerge. I mean, come to New York, we have Elliot Spitzer, Weiner, all these guys who, their pathologies are out there, they disappear for a couple of months, and then they're back. You could do that as an adult. As kids, you can't. When you're a child and you are suffering with an emotional disorder, you're taken off the developmental track. You get behind as compared with peers who are your age. And there's a lot of costs and things that happen that make it much more difficult to get back on track and move along. So lost hope, lost time, solidifying of the issues are so important for us to go in. The other thing, too, about empirically supported treatments is they preserve the integrity of the field. When we can get together and get behind promoting what works, then we stand united as a field, which is important for us. And it also allows us then to continue to develop and refine and create new ways of treating kids in different means and stuff. And that's fine, too. That's important for the field. But not everybody is on the empirically supported treatment bandwagon. And there are many, especially insight-oriented therapies, where they argue against empirically supported treatments. In this way, what they say, and their number one argument, is that these treatments do not lend themselves to randomized controlled trials. I don't think I've met a treatment that can't be put into a research agenda and defined within a research context. And I'm going to talk about how we do this in a little bit. The idea that you can't manualize therapy and therapist intuition and experience, again, too, I don't agree with that, but these are the main arguments against going after evidence-supported treatments. And this is a quote from the Academy for the Study of Psychoanalytic Arts. Many family systems, existentialist, humanist, feminist, psychodynamic, and psychoanalytic therapists find their own ways of thinking about human experience incompatible with the model of empirical support used by empirically supported treatment advocates. I find that very sad and alarming, that you wouldn't want to know more about what you do in terms of why or how it works, and how then to use what you learn to improve upon your methods. So this is what we are up against in terms of the arguments against empirically supported treatments. Now, in the 80s, with the shift and where we went after empirically supported treatments, it started to become very important. Here, what happened was, by 1990, Dave Barlow, as president of Division 12, this Society for Clinical Psychology within the APA, commissioned a task force headed by Diane Chambliss. And this is a busy, busy slide. You'll get this tomorrow or later today when you get to handouts. But essentially, like in other areas of medicine and science, it laid out what was meant by evidence to support a treatment, what you needed to do in order to show and demonstrate that a treatment was empirically supported. And the thing they're asking for is at least 2 well-controlled studies where you're comparing groups. I'll show you an example of one that we did later, where you are showing that the treatment in question is superior to a pill placebo, if there is one, or a pill for that treatment, or a psychological placebo, or another type of treatment that works for it. So you're comparing things. Does it work as well as or better than these other things? That's important to know. And I don't know why that's not something that should be standard across the board in anything that we do. That's what we're asking for, though. Or it's asking that you take a treatment that exists, that we know works, and that your treatment that you're studying is equivalent in terms of its effects. In the absence of these group-based studies, these randomized controlled trials, it's asking that you really have a lot of evidence in terms of small single case studies. And this is where we trip over ourselves, because a beautifully written poetic description in a case study or in a case narrative is not a case study where you evaluate the patient at the beginning, you follow them, and you take data that's focused on certain outcomes, and that data is being taken oftentimes by someone independent from the therapist, and you can show change in that patient or a series of patients in what's called a single case design methodology. They're small, they're very powerful, they're very useful, so you need a number of these rather than just description, 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 because descriptions inherently are filled with bias from the therapist who's treating the person. So there's different, this is for well-established treatments, and then probably efficacious treatments are those where you have 2 experiments showing that the treatment is superior to a wait list or another type of control group. And, so there's different levels. We look at what's well established, what's probably efficacious, and such. This comes from a website. There's this very good website called ssapsychology.com, where Dr. Singh pulled from the empirically supported treatments list what works for the different types of childhood disorders. You have the type of disorder in question, the empirically supported treatment, and the level of support, whether it's well supported or probably efficacious. Now, the interesting thing here, I'm going to see if I have a pointer. Yes. The interesting thing, so for adolescent anorexia nervosa, what is empirically supported, family therapy, the Maudsley approach for eating disorders, and it's well established. And people would agree with that. There's numerous studies, independent, conducted by different independent sites, that shows that this treatment is effective for adolescent anorexia. And you see cognitive therapy by itself is experimental. It's not yet established as an effective treatment. They're still working at it, and maybe it will be, or maybe it won't make the empirically supported treatments list. But the thing of it is, proponents of cognitive therapy are continuing to work and try to understand that. Now, with anxiety disorders, I'm going to show you some examples in a minute, but if you look at the different types of treatments that we have for anxiety in youth, from individual CBT, from group CBT, exposure treatment, family-based CBT, parent CBT, what you see is probably efficacious. Okay? It probably works. Now, mind you, this slide and these designations were published prior to the end of a trial that I'm going to show you in a minute. But what these probably efficacious designations did for us in child anxiety was make us work hard to really understand what's going on. If you continue, child and adolescent ADHD, behavior therapy, you see well-established treatments in terms of parent training, classroom management, peer intervention, everything you see at the summer treatment program for ADHD that was developed by Bill Pelham and available down here at FIU. For early autism, well-established behavior therapy, and those of you who have heard applied behavior analysis, that falls in that realm. Child and adolescent bipolar disorder, probably efficacious. Family therapy, I think you might be hearing from Mary Freistad later in the week, so you'll hear about that. When it comes to adolescent bulimia, probably efficacious. All right, bulimia differently from the anorexia treatments. Guided care for binge eating, and again, the Maudsley approach. And then you have CBT for depression and interpersonal therapy for depression in children or adolescents. And you have different levels here, well established in terms of the group child-only CBT for depression, probably efficacious for behavior therapy. And you see still experimental where it comes to child, right? Group psychoeducation with parent family therapy, probably efficacious, and so forth. So we can rely on these kinds of lists that are out there in the field to give us a sense of what's going on, what's efficacious, and what isn't. And this is important because insurance companies are looking at this, the Affordable Care Act is looking at this, but therapists need to look at this. Now, I want to talk about why randomized controlled trials, why we need to do these. And I'm saying this to you, understanding that randomized controlled trials are the mainstay of how we find out if a treatment works. If you go to your doctor at any point and you need, some kind of medication, whether you're presenting with strep throat or you're presenting with pneumonia, whether you're presenting with a cardiac issue or what, I hope you're getting treatment that was studied in a randomized controlled trial. Because that's where medications and that's where treatment guidelines come from, is what has been found through the science of medicine to know what to deliver to you depending on what you're presenting with. Well, the same way with us. So in terms of anxiety disorders, when we saw in the literature that CBT was effective for upwards of about 60% of kids, But we knew also there was medication out there. What we needed to do was understand what works best for whom, and also we needed to understand what actually happens in the real world. In the real world, most kids get both, believe it or not. They come in, even to our specialty clinic for anxiety, they come in already on medication. So this CAMS trial that we did was taking kids with separation anxiety, social, and generalized anxiety disorder. They were 488 kids between 7 and 17 years of age, and we randomly assigned them to receive either cognitive behavior therapy, medication, one of these SSRIs, the combination of the two, or pill placebo. Now, why is this type of study different from narrative reports and case studies and things you see in the literature that many people use to support what they do? Random assignment is so important. We as investigators didn't know what any given kid was going to get. It's generated randomly as to what they're going to get, and the parents and families didn't know what they'd be assigned to. So they were randomly assigned. And then the other thing is we would know what therapy they're getting. Obviously, we're studying CBT, but in the conditions where they had medications, no one knew if it was a real pill or fake, unless they were in the CBT plus the active medication. We knew that. But if they were getting pills only, we didn't know if it was placebo or real meds. The other thing is blind independent evaluators. We had separate evaluators who didn't know what treatment the kids were getting, didn't communicate with the therapists, but met with the children periodically before the treatment started to assess them and see where their anxiety was, and then every couple of weeks throughout the course of this trial that went on for 6 months. Went on for 12 weeks initially and then another 6 months. So we kept blind from understanding the treatment condition. This is important, and this is what you don't see in the literature that attests to some of when you see testimonials and things, they're talking from a bias that we try to remove in science. And then we evaluated these kids at acute 12 weeks and then also at the end of the 6 months to see if they maintain their gains. The coping cat was the treatment that we used, Phil Kendall's work, the most well-established treatment for the anxiety disorders, manualized, absolutely, tells you what to do. And Phil coined the phrase, flexibility within fidelity. No, he's not advocating for infidelity. Flexibility within fidelity. That is, the coping cat in clinical practice can be applied, you don't have to go session by session. You use it according to what the children bring to you, what time you have and such. But this is the best. The stick tasks are show that I can. These are tasks where kids do exposures. And then for the 7 to 17-year-olds, we've had age-appropriate exposures and such for them, somatic management, psychoeducation, and parent sessions every fourth session we saw the parents. These are the outcomes. The outcomes here now, in a randomized controlled trial, demonstrated that 81% of the kids in combination treatment got better, really significantly better. And this was better than anything else. Combination treatment beat all. So the combination of medication and CBT we saw is the way to get on top of child anxiety. But at the same time, cognitive behavior therapy and the medication were equally effective and significantly better than pill placebo. The take-home message, and then after 6 months, we had a similar response that their gains were maintained in the kids who were treated. The take-home message now that we can confidently give to families is that you have a choice of 3 things for your child who has anxiety disorders. You can go for combination treatment, you could go for CBT, or you could go for medication. This gives them choice to look at what's available where they are, because not everything's available everywhere, but also what their preferences might be. And we are working now in the follow-up study to understand what families did after this study ended, and then also what the long-term results are over the longer time, and what preferences were and such. This is why research is important, because you can really stand on and tell parents, with a degree of confidence and surety of how things might go for your child, okay? Now, the thing of it is, this therapy now, we understand CBT, this psychotherapy is grounded in theory, sound principles, treatment plans address the individual patient needs, it's flexibly applied, and the empirical support is strong, and yet not many people are listening to us. I can't tell you day in and day out at an anxiety specialty clinic how I have kids who come in who, just have never had CBT, but they've been struggling with anxiety for a number of years. There's a research to practice gap. Something's going on that we are not translating to the field, or the field isn't accepting what we understand as good evidence and outcomes. And a lot of what I hear from people in the field is, well, those kids you treat in your studies are not like the kids we see in the real world. So I just want to describe one young girl who came to us, Mandy. She came to us when she was 15. But her history showed that she had always been a worrier, she had always been separation anxious, and at age 11 was the first time her parents took her for treatment. This is a child who at 11 couldn't do schoolwork, didn't want to go to school, would cry, even though she was brilliant. She had 130-something IQ, full scale. There was no differences, no learning disabilities. She had a neuropsych done. She was doing fine intellectually and the way that she was developing in an intellectual sense, but she could not separate from her parents, slept with them at night. Lots of complaints about school, lots of complaints about being out of the house and away from everyone, high achieving. Weekly therapy began based on the neuropsych. Started refusing to do schoolwork where she would just put her head down at school. By the 8th grade, what happened to her was that the therapist, who actually had also done the neuropsych and then took her in for therapy, went from once a week to 3 times a week by 8th grade because the child was more and more refusing school. And they then added in medication. By 9th grade, she was not going to school at all. And so in 9th grade, the therapy, again, the medications were increased, and the traditional talk therapy was now every day per week. Think of the cost in terms of, thank goodness it was a family with means, but think of the cost to this girl. She wasn't seeing friends, she wasn't getting educated, she was refusing all kinds of stuff. Finally, in frustration, the mom and dad one night took her computer away because she wouldn't comply with seeing the home-based tutor that they brought in to see her. And it was in response to that this girl took her whole bottle of medication and wound up in emergency room and then inpatient, at which point she comes to us at age 15. Now, I would argue to you that no, when she came to us at 15, did not look like the kids in our study because she was completely school refusing. She had been hospitalized. She was already on all these multiple medications. She was going to therapy 5 days a week. No, she didn't look like the kids in our study. But what I would argue to you is that at age 11, she looked just like the kids who were in my study. And so the thing of it is, why was she continued in the same therapy? Now, I can't blame the parents because they are trusting the professionals. The research to practice gap, what we have to look at is there are different types of gap problems that occur. First of all, evidence about an intervention. If there's evidence that an intervention has a positive effect and the intervention is provided, no problem. If the intervention is not provided, this is a failure to translate what is available to giving it to the patient. At the very least, this child we saw then at 15, this was a failure to translate. The therapist should have tried to get help more than just medication. There were other psychotherapies, right? Evidence of a harmful effect may occur in some where there is an intervention proven to be harmful, yet it's given to a child well, this is harm. This is, that tenet, do no harm, this is doing harm, okay? That's what happens if you apply an intervention that's been shown to be harmful. Evidence of no effect, well, what's happening here, the research to practice gap, if you give it this treatment, it's opportunity costs. You're losing time. The child loses time on the developmental trajectory. Their anxieties or ADHD or oppositional behavior solidifies, more comorbidities. Over the course of time, we know the longer a kid struggles with a disorder, the more likely they're going to pick up other conditions. And then if there is evidence of there's no available evidence for a treatment, well, that says to me, bring that treatment into a researcher and try to figure out what's going on. Because that's an evaluation gap. You're applying something that we don't yet understand, and we need to understand. Would you take a medication without it having been tested? Maybe you would. I don't know. I wouldn't. But anyway, so these are the things that we're dealing with in the field. Now, what happens is, unfortunately, the reason why those research to practice gaps have levels that say harm, opportunity costs, right, evaluation gap, is because there is something we call pseudoscience. Scott Lilienfeld is eloquent on this. He's got YouTube videos, he's got publications. Pseudoscience is where practices are being performed and beliefs are being held or theories are out there which people think are valid and consider them valid and scientific, but they really don't have empirical support. And we must watch out for where there are narrative, beautiful descriptions of cases, but not with empirical evidence. And some pseudoscience types of therapies have actually been disproven, but still they persist. They may lack empirical support, but still they persist, or you cannot test them. Well, we will argue that maybe you can. I mean, that's something that we have to try and see if we can, otherwise put them aside. And unfortunately, these types of pseudoscience therapies are prone to research to practice gaps. High-profile pseudoscience, first and foremost, you're going to hear from my colleague Bob McMahon about treating disruptive behavior disorders and effective ways of treating these disorders, and yet we still have people who send kids to boot camps and scared straight. There's lots of evidence that shows that these actually do harm to kids, as opposed to helping the overwhelming number of kids. They do harm. And yet, they persist, and they cost a lot too. So they're draining families in a lot of ways, but they're also solidifying anger, rage, and harm in children. And of course, here in Florida, up north, we've been watching in the newspapers what's going on with the Home for Boys, where they are digging up mass graves of some kids from a place where they were, I guess, in the 50s and such, sent away. It's terrible, but this is one of those early types of send kids into a scared straight type of an environment. In the worst case scenarios, those things will make the news. Equine therapy, Scott Lilienfeld and colleagues have a wonderful review in literature of what's been published in terms of studies on equine therapy. And unfortunately, when I listed out the CAMS trial, independent evaluators, blind to treatment condition, random assignment, none of the equine therapy studies meet any of those criteria, but one that had a control condition, but the children were able to choose between going and riding horses versus staying in the classroom and doing classwork and a classroom-based program. There's a little bit of a bias there, so of course they reported liking and doing better on the horses. Unfortunately for equine therapy at this point, research to practice costs, our opportunity costs are happening here. We're losing time for these kids by sending them to do something that may be pleasant, but isn't therapeutic. It is not therapeutic. And down here in Florida, as much as I love Flipper, there is no evidence for the effectiveness of using dolphins in treating kids with any kind of emotional issue, especially autism. And you'll hear from Kathy Lord later this week about what actually does work in the treatment of autism. And this, I will just have to tip my hat to Florida International University, because what happened here is that dolphin therapy actually began at FIU with Dr. Betsy Smith. She was inspired by watching a dolphin interact with her brother who had a mental disability back in the 70s. And this happens. People get inspired by seeing something at one little period of time, a child opening up, a child being happy, and they think that this works. So she put a lot of work into dolphin therapy, but then in evaluations, she saw it doesn't really work to sustain change in the children. And now she herself was quoted, this comes from the Washington Post, that it exploits vulnerable people and vulnerable dolphins. So she had no idea, she says, what we were unleashing. And so dolphin therapy is a nice exercise and a lot of fun, but it is not a therapy. It shouldn't be promoted. Rage reduction therapy, you could call it attachment therapy, holding therapy. This does harm, extreme harm. And we know there's plenty of examples in the literature and in the popular press that had come out about this, wrapping kids in blankets they smother to death. Okay? The costs in terms of the child and what happens to them over the longer term, even in the immediate sense, if they, of what happens is terrible. It's been linked to several deaths, including asphyxiation in kids. So we have to watch. The proponents of attachment theory came out very strongly against use of the term attachment therapy. So this is from Howard Steele. We must acknowledge there is no systematic evidence-based approach for treating children with attachment disorders. Moreover, the very concept of attachment disorders is controversial. These are leaders in the field of attachment theory saying this. Holding therapies have not been shown to be an effective clinical tool and may be seriously harmful and counter-therapeutic. These from the people who are proponents of attachment theory. So please, we have to read critically the literature. He goes on, we may not yet have an agreed set of definitions as what counts as attachment therapy, but we can rule out certain practices as being incompatible with the ethos of attachment theory. So these holding things get rid of. They're working for certain types of attachment-based therapies that have to do with the dyadic interaction or the interaction between parents and the kids. We're not throwing the whole thing out in that sense. But certainly these practices of securing a child, holding a child like that, are not viable. And then, of course, conversion, reparative therapy to convert kids who are gay, LGBT, transgender. This is completely discredited. It's a dangerous practice resulting in serious harm. Most recently, we've seen the case of Leela, a boy to girl who was transitioning or trying to transition. Parents sent her to conversion therapy, and what she did was threw herself in front of traffic. If you're reading this, it means I've committed suicide and obviously failed to delete this post from my queue. She had it all set up, made a plea to please stop doing this conversion therapy. Please accept people who are of different orientation. This is a map from the Southern Poverty Law Center showing the pervasiveness of conversion therapy around this country. Even though it's been shown to do great harm, is not effective. It's a pseudoscience, pseudotherapy. What we have in terms of traditional talk dynamic therapy is an evaluation gap. We need to study it. Play runs throughout all of our therapies with kids, but we have to understand when you're talking about more traditional therapies and play therapies, do randomized trials to see what is going on and what, with or without aspects of other types of interventions put in with them. There's those who say they do cognitive behavioral play therapy and such. Well, let's find out what are the effective ingredients of play therapy. The thing here is, I'll tell you about a young girl who was 5 years old, New York City. I don't know, I'm a transplanted New Yorker to Florida, and then I transplanted myself back. But you've got a lot of transplanted New Yorkers here. More and more it's happening. I don't know if it's caught on back home in New York City. If you find out that you're expecting a child, you put them on the wait list for a kindergarten of your, the certain kindergartens, and you also get them in line for therapy. Kids enter therapy in New York by the age of 5, and so there was this young girl entered at the age of 5 for self-esteem issues, and was working with a parent. She actually had separation anxiety and stuff. Started working with a traditional therapist. By age 8, she was doing twice a week therapy plus medication for her separation anxiety. Okay, at age 10, I get a phone call that they wanted, this is the other thing in New York, is by the age of 10, even though you might have ADHD, anxiety, whatever it is, during the summer you're going to camp, right? So the parents wanted to send her to summer camp. They called me at like the middle of May, camp. She was supposed to go to camp in the middle of June. The therapist and the psychiatrist said, you can fix her separation anxiety so she could go to camp. And that's how I got the history of age 5, age 8, the whole thing. I'm like, well, you're giving me 4 weeks. Okay, we'll see what we could do. And sure enough, I was able to work with her enough to get her to go to camp. And I said to the mother, but please, when she comes home from camp, we got to continue and finish out our work on these anxieties that she has. Never heard from them again until she was 12 and a half and started having panic attacks. At which point the mother called me and said her therapist, who she has continued to see since the age of 5, her therapist said to call you to see if you could knock out those panic attacks so they could get back to working on her self-esteem. At which point I said to the mother, what's going on? What are the goals of that therapy? And the mother said, to build her self-esteem, make her feel better. And I said, and what do you mean by that? Well, I don't know, but they're building her self-esteem, and she likes to go. I said, well, it doesn't seem to be doing much for the anxiety, does it? I said, let me ask you something. What's her self-esteem going to be like when she's 30 and looks back on her childhood, and it was spent with this guy twice, 3 times a week since the age of 5 in therapy? I said, I think kids should, we should try to deal with what's going on with them, but let them be kids. They should be playing with other kids, not with therapists. So anyhow, she came in, we worked on it, and I worked with her for a good year because it was more than just separation anxiety. It was separation anxiety, generalized anxiety, and off she launched, and no more therapy. The thing of it is we need to evaluate what's going on in these other treatments and bring out the most effective components if they're there, right? None of these treatments have been subjected really to scientific study. It's anecdotal case report. And the question we always have to ask, would you rely on this level of support for your own medical conditions? Why do we do that? I don't want to fall prey to the inert hypothesis, which is if it hasn't been tested, it's ineffective. I'm not going to do that. I want to test these treatments. So that's what people at FIU and those of us who do this, we want to join and do as much testing of treatment as possible. Why aren't empirically supported treatments the standard for childhood disorders? Why are we continuing along the lines of this evaluation gap, research to practice gap? Is it a sign of the decline of child therapy? There's something we have to bear in mind. This here is what's offered in training programs in medicine, psychology, Ph.D. and Psi.D., and social work. What's going on in training programs? The yellow bar is offering some kind of training on empirically supported treatments. The blue bar is requiring that the trainees learn about empirically supported treatments. Just learn about them, not learn them to a competency, but just get exposed to it. It's interesting that medicine, psychiatry is mandating that they learn about empirically supported treatments in psychotherapy, but psychology and social work is not. okay? And there's a split. In psychology, you do better in a Ph.D. program than a PsyD program for learning about them, but not to competency. That's pretty bad. In New York State, we ran a program for the state of New York, 779 state clinicians. In taking these clinicians from community mental health centers, we gave them workshops in empirically supported treatments and then phone consultation over the course of a year to help implement the empirically supported treatments. Predominantly, they were social workers or master's level, and their level of experience in empirically supported treatments was largely on the lower side, little, some, 50% or less in terms of a lot or expert. And what happened is, they had didactics, role play, then they had consultation and such, and we also did consultation for their supervisors. What we found on these consultation calls, we couldn't get data at the patient level, but what we found is that these therapists were really into wanting to understand how to use these treatments. They stayed on task on the call. They talked about the specific assessment and treatment techniques. These were mostly what they were interested in, and they were very satisfied with having gotten this training. The sad thing is, though, they're getting it after the fact. They're not getting it in grad school. The thing that we have to do as clinical child psychologists, because we've developed these treatments, for the most part, it's CBT folks and other evidence-based treatment folks, interpersonal therapy, we've developed them. We have to get into the master's programs. We have to help people learn these treatments before they get out into the community so that it's easier in the community settings to implement, right? Because, these are the most prevalent therapists now are master's level. They're the most cost efficient for the system, and they're very eager. They want to learn. When you do supervision in empirically supported treatments, you'll hear from Marty Franklin later in the week, so you're likely to see this slide again. It's his. This is from his slide of the pediatric obsessive-compulsive treatment study, again showing placebo was the worst. Sertraline didn't do too well, the medication, but I think it did separate from placebo. But cognitive behavior therapy or the combination were superior, right? They got OCD. They treated kids with OCD, and those two treatments, CBT or combination, outperformed everything. But when you looked closely at the data, what you can see then is that in the site where CBT expertise was at its highest, and that's Marty's site, CBT outperformed combination treatment. Okay? CBT outperformed the medication in a site where you had experts and what we think very good supervision. So supervision is key, and consultation is key for training people and keeping people at the standard. What's missing is that our accreditation bodies don't require competency. When you graduate from any kind of graduate program, you don't have to be competent, just have to be exposed. And yet, in healthcare reform now, the Affordable Care Act, believe it or not, I live with someone, my husband, who read the whole thing. He read that thing. He understands it. Thank goodness. Evidence-based practices are being required, all right? They're being required, so we have to, as a field of child therapists, get on the bandwagon, because the other evidence-based treatment is not a psychotherapy. It comes in a little tiny form, sometimes pink, sometimes blue. When you look at the main studies, medication versus therapy and combination in child, from the MTA to the treatments for adolescents with depression to pediatric OCD to the CAMS anxiety study, you find medication is always in the first column in some form, either medication alone, methylphenidate, combination. These outperform everything else. And unfortunately, the press loves it. The headlines in the press after these research studies for the MTA, stimulant drugs are most effective. Bill Pelham's going to knock that one out of people's minds during this week, because we know in the acute 12 weeks maybe it was, but not over the long term. And there are many, many serious side effects and issues that happen. Talk therapy doesn't work is what we heard from TADS. Again, in the acute 12 weeks, medication will come on fast, but the therapy comes on a little bit longer and stays the long term. Here, treatment effective for OCD in the POTS trial. The press wasn't willing to give talk therapy or CBT headline, and combination best treatment in the anxiety study. The press messages are really confusing. But what's happening in the country now from 1998 to 2007 is that pharmacotherapy is the way we're treating mental illnesses. Pharmacotherapy is the way we're treating mental health and behavioral problems, all right? Here is another slide, and I will shamelessly self-promote. It is my husband's work, these slides. Here, from this slide, 97 through 2005, what you see is millions of Americans in the use of antidepressants in the yellow versus psychotherapy in the blue. All right? And then most significant for this audience is this slide, the use of antipsychotic medications in children. Right? And these are not kids with Medicaid. These are privately insured kids. So just so you know that. And what essentially they find is if you are a boy between 4 to 5 years of age, you're likely, if you have a disruptive behavior disorder, autism or anxiety, you're going to get put on an antipsychotic. By 4 to 5 years of age, and there's no data to support this really, no big randomized controlled trials. But this is where the country's at. For these reasons, it is so important to get the word out about effective psychotherapies, all right? We don't have an industry who's helping to support this message. We don't have somebody who's putting up direct-to-consumer marketing advertising pieces. And as a field, we remain split on this. We need to come together. We need to come together with this message, otherwise we're going to be put out of business in a lot of ways, but more importantly, kids are going to suffer. And they're going to suffer more significantly than ever before because they're going to be put on medications more earlier on. We need to change the graduate training agenda and make graduate programs train people in evidence-based treatments and give a clear message. And we need to do a lot of consumer education around this. To secure the future of clinical child and adolescent psychologists, focus on the development of treatments and the further refinement of those that work, adapt these treatments to the changing demographics of what's going on in this country, because we have to study these treatments as they apply to new populations and things that are going on in that way. We have to require training. We need to be the leaders in assessment and treatment, which we have been in the past. We need to get back up there again. And oversee the extant mental health workforce, because practice teams are going to be the way in private practice and in primary care settings, so we need to be in that. But most importantly, we need to unite around evidence-based treatments. If you're here, which you are, you're here because you're interested in evidence-based treatments. EffectiveChildTherapy.com is a phenomenal website co-sponsored by FIU, the Division of Clinical Child at the APA, and other sponsors that keeps up to date what's going on in these treatments, has videos, as you know. I send a lot of the parents who come to our clinic to Effective Child Therapy to look at the videos so that they get a sense of what we're going after. And this helps to set the stage for the treatment. And then I will wrap this up because I'm going to turn you over to my buddy, Dr. McMahon, in a little bit. But in the meantime, I'll take a few questions.